Good afternoon. My study was on the topic diagnostic accuracy of Van Herk technique compared to gonioscopy in detecting primary angle closure suspects among eclipse sign positive cases. The prevalence of primary angle closure glaucoma is high and it may be prevented if occludable angles are identified earlier. Instead of time-consuming procedure like gonioscopy, we need simple procedures like eclipse sign and Van Herk technique. This was a hospital-based cross-sectional study in patients of age more than 40 years with positive eclipse sign attending our OPD from November 2019 to April 2021. Those with diagnosed glaucoma, primary angle closure disease, secondary causes for angle closure glaucoma, and previous history of ocular surgery and injury were excluded from the study. The primary objective was to study the diagnostic accuracy of Van Herk technique in detecting primary angle closure suspects compared to gonioscopy in eclipse sign positive cases. And the secondary objective was to study the influence of corneal white-to-white diameter, central antechamber depth, lens thickness, and axial length in detecting primary angle closure suspects. 200 eyes of 100 patients were included and all of them underwent Van Herk grading and Schaeffer's gonioscopy grading. Those with iridotrabecular contact more than or equal to 180 degree was considered as positive in gonioscopy. Corneal white-to-white diameter, corneal central antechamber depths, lens thickness and axial length were measured. Lens position, relative lens position and ratio of lens thickness axial length ratio were calculated and these were analyzed using SPSS20 software. Independent t-test, ANOVA test and ROC curve analysis were done. P-value less than 0.05 was considered as statistically significant. Coming to the results, majority of them were females, which was 66%, and highest number was in the age group 51 to 60 years, which was 39%. 141 eyes were turned out to be positive in gonioscopy. 90.6% of Van Herk's grade 1 eyes were positive. In age group 71 to 80 years, all of them were positive. 80.9% of males and 65.2% of females were positive. With the cutoff of Van Herk's grade 2, sensitivity was 95.04 and specificity was 33.9. With the lowered cutoff, it was 61.7 and 84.75. The mean axial length and corneal white-to-white diameters were significantly smaller in females and lens thickness, lens position and lens thickness axial length ratio were more in males. Lens thickness was higher in age group 71 to 80 years and mean axial length was significantly lower in each class 41 to 50 years. The ROC curve of lens thickness and lens thickness axial length ratio showed area under the curve more than 0.5 but both were statistically insignificant with a p-value more than 0.05. The proportion of females was more in the younger age groups and they had significantly lower axial length and corneal diameter. The proportion of males was more towards older age groups and they had significantly higher lens thickness, lens position and lens thickness axial length ratio. The majority had Van Herk's grade 1 as only eclipse sign positive eyes were included. In a study conducted by Chowdhury et al., which included both narrow and open angle clusters, the majority were Van Herk's grade 3. The maximum number of disease positives were in the age group 51 to 60 years, same as Chennai glaucoma study. The proportion of males becoming positive was more than females, which may be due to larger lens thickness, lens position and lens thickness axial length ratio in males compared to females in the sample. In our study, with a cutoff of Van Herk's grade 2, the sensitivity was 95.04 and specificity 33.9. With the lowered cutoff, the specificity increased to 84.75%, which was comparable to the study done by Chowdhury et al. To conclude, the Van Herk technique can be used as a screening test to detect primary angle closure suspects among eclipse sign positive eyes with a sensitivity of 95.04%. With the cutoff of Van Herk's grade 1, the specificity increases to 84.75, for which we can consider prophylactic laser peripheral iridotomy even without gonioscopy. In younger age group, shorter axial length is a risk factor for primary angle closure suspects, and in older age groups, increased lens thickness is contributing more to the risk of developing PACS, and hence early lens extraction can be considered in this age group. The biometric values and the derived values give additional information about the risk of developing primary angle closure disease. The limitations of the study are small sample size and inter-examiner variations in Van Herk grading and eclipse sign test. These are my references and thank you.
Okay, did you do peripheral iridotomy in any case without gonioscopy?
Usually we don't do.
No. In your study, did you do for any patient?
No.
Is it advisable?
No. According to the available studies, it is not advisable. Without confirming by gonioscopy, we cannot proceed into peripheral iridotomy. But this was an attempt to study whether we can proceed to peripheral iridotomy even without gonioscopy, like time-consuming procedure.
That gonioscopy is not a time-consuming procedure at all.
It need more experienced ophthalmologist to perform gonioscopy.
Every other PG student or resident should be well versed in doing a gonioscopy.
Madam, in a busy OPD like ours,
You
gonioscopy
cannot
is...
say busy.
Yes,
Your conclusion is that in men it contributed to the cataract. So is there any point in doing laser in them?
No, madam.
So you cannot make a generalized statement like when it is Von Erich's grade 1, laser iridotomy, no. There are other underlying causes of shallow AC.
Yes, madam. Madam, males, most of them were in the older age groups and in them lens thickness was more. We advise, yes, ma'am.
You cannot conclude it like that. That's not acceptable. What percentage of PACS go into angle closure?
Around 10%, 7%.
Less than that. So that means to avoid that many angle closures, you have to treat these many patients. No.
Yes, ma'am. Thank you.
Why did you include both the eyes?
Because it is a bilateral disease. Okay.
One, was all the observation done by a single person? You said in the end only you revealed that there was an inter-observer variation.
Yes, ma'am. Madam, it was done by a single person. No, madam, it was done by a single person.
Back was that inter-observer variation.
What I meant was if another person is doing it. Okay. Okay.